My name is Sharona Ben-Haim. I'm a neurosurgeon at UC San Diego, primarily treating adults, and I'm joined by Allyson, who is a neurosurgeon in Colorado, who specializes in pediatrics. And so we will cover a couple of things today, surrounding minimally invasive epilepsy surgery. But I'm going to start really by giving more of a general overview of epilepsy surgery, sort of how we think about it, how we make decisions about epilepsy surgery. This does come, my presentation does come from the lens of an adult center, which is a little bit different than a pediatric center, but of course a lot of the same sort of shared principles. We have the luxury of having kind of a small room and a small group of people. So if there's any questions or anything at all about the talk, don't hesitate to just raise your hand, and I'm happy to entertain questions at any time. Okay, so let's see if this thing works. I'll just go here. Okay, this one doesn't seem to work, but oh, there we go. Okay, great. Okay, so, it's important to kind of just, yes?
I'm sorry to interrupt.
Yep.
Oh,
to speak. Sure. Okay. Can you all hear me okay? Can you hear me better?
Yes.
Okay, great. Okay, so the first thing that's important to note is that, the way we think about epilepsy surgery on the whole is that it's a quality of life surgery. That's really the whole point of undergoing an epilepsy surgery. It is because you have seizures that are impacting your quality of life, first and foremost, ones that are not adequately treated with medications. And so the way we think about, what kind of treatments we offer an individual patient are really through the lens of, will this improve your quality of life? That's our goal. And so, I'm sure you've heard this many times today already, but there is a category of epilepsy called drug-resistant epilepsy, and that actually applies to somewhere between 30 and 35%, by some estimates even more, of patients. And that is when, there's a very kind of specific definition of that, which is when a patient has failed 2 or more anti-epileptic medications. And the reason that this definition came about is because, now we have, 30, 40, who knows how many anti-epileptics on the market. And so you could spend a whole lifetime going through each and every one of them, not fully achieving seizure freedom. And so you don't have to try every anti-epileptic out there to consider yourself drug resistant. We do have good evidence that shows that after the second medication, if someone still fails, you might want to consider something like beginning a surgical workup. And I'll talk a little bit about what that means now. And again, it's that definition came about because we don't want patients to spend their whole lives trying different AEDs, before considering other options. So you can't see the slide that well, but I'm going to talk through a little bit about how we begin a surgical evaluation. Now, I think a really important distinction to make up front is the difference between what we conceive of as a focal epilepsy that may or may not secondarily generalize, and a primary generalized epilepsy. Those are really two sort of different categories of things. And when I say I'm speaking from the lens of an adult center, I'm really going to talk about a surgical workup that applies to patients where we suspect there is a seizure focus. Okay, we may not be right ultimately, but that's kind of the suspicion coming up front. To go through a workup like this, we think there's a seizure focus that we might be able to identify. And so the whole goal of a surgical epilepsy workup is to really answer the question, can we figure out where in the brain these seizures are starting? Can we figure out where they're coming from? Again, they might be starting there and then quickly going other places in the brain or spreading or generalizing. But the real question is, can we figure out where they're coming from? And so, it's pretty surprising, but to this day, we don't have one specific non-invasive test that just pinpoints it all for us and tells us, okay, seizures are coming from here, from this spot in the brain. A lot of the patients we see in our epilepsy center have completely normal MRI scans. Sometimes MRIs do have some findings. For example, we might see sclerosis in the mesial temporal lobe, and that's a really good finding that says, okay, it's a big red flag, seizures might be coming from here. Or sometimes there's just a full-on lesion or a cavernoma or something else suggestive, that might be the seizure focus. But a lot of times we're starting with a perfectly normal MRI. And we're still left with the question of where are seizures coming from. And so we go through a staged workup, basically getting a lot of different tests that all give us more clues as to what might be going on with this particular patient's seizure network. And so that involves, of course, just the basic background, history and physical examination, which we can tell a lot from. Imaging, like CT, special MRI scans. Sometimes we get MRI scans from the community, and they're not quite the same as our epilepsy protocol MRI scans that we get at the university. PET scans are really a mandatory part of this evaluation. They really help us understand metabolism in the brain, and sometimes places where seizures start actually exhibit decreased metabolism, and that's something that, again, just provides us one more clue to add to this investigative process. A comprehensive neuropsychological evaluation, that's really a battery of tests that tests all sorts of different functions like verbal memory and visual memory and attention and processing speed, and all these things that might also give us clues as to where seizures might be coming from. And then I skipped over inpatient scalp EEG monitoring because that's really a cardinal portion of what we call phase 1 of this epilepsy workup. And that's when patients come to our hospital, they get admitted, we put electrodes on their scalp, and we have a video camera pointing at them, really so that we can see exactly what happens when seizures start, both physically, what the patient is actually doing, and then we have real-time electrographic activity of what's going on in their brain that second that seizure starts. And that's exactly what we're trying to figure out. What's happening right as the seizure starts, or just before the seizure starts even. Because that gives us clues as to ask this question, where is this all coming from? Where is this starting? And so, here are just some imaging that you see here, like a example of a PET scan. We might consider, after doing this first phase of the evaluation, some more specialized testing, like fMRI. This is an example of an MEG scan. That's a really nice scan that shows us interictal activity, so activity in the brain in between seizures, which can help us understand what's going on during a seizure, but it's not a perfect test. And I think the bottom line is we don't have one perfect test. We just have a lot of different tests that contribute information that then give us a bigger picture of what's happening. And so after we get this kind of first phase of the evaluation, pretty much at every major epilepsy center, we meet together in a surgical epilepsy conference. And at our institution in San Diego, this is a conference where we have neurologists, surgeons, including myself. We have epilepsy specialists and radiology. We have our neuropsychologists. Usually there's something like 20 or so physicians at this conference. And we have this conference at our place. We have it once every other week on a Friday. It's scheduled for about an hour and a half, and we can get through definitely no more than 2 patients, because each patient normally takes about almost an hour. Because it's a lot of data, and we need to all process it together to get that bigger picture. And so that's really important. And so what we're looking for here in looking at this data is, do we have concordant data? Is everything pointing us to one spot? Is everything localizing to one area? And if that's the case, then we have this rare opportunity to say, yes, we've identified it, we found the area with non-invasive testing, and we can therefore say we feel pretty confident we know where the seizures are coming from, and then we might consider that patient a surgical candidate. And I'll go in a little bit about what types of surgeries we consider. Sometimes we go through this first phase of the workup and it's become clear to us that we're not actually dealing with a focal epilepsy. Maybe we're dealing with a generalized epilepsy, or maybe we're dealing with really a multifocal phenomenon, and we probably are not going to be able to localize it. That's still really important data for us to get. And then from that case, we consider some sort of our palliative surgery interventions. And I know there's various talks today, just focused on these things like neuromodulation, deep brain stimulation, responsive neurostimulation, and the various, reasons one might consider doing those. Sometimes we have some idea of where things are coming from. We have a hypothesis. We think we know where seizures are coming from, but we're still not confident enough with our basic non-invasive testing to say we've figured out where the focus is. And in that case, we might opt for an intracranial EEG monitoring exam. And that's when we repeat that inpatient scalp EEG that with a video camera, only this time, instead of the electrodes being on the surface of the head, we actually physically implant them into the regions of the brain that we suspect seizures are coming from. And we usually get a really good idea. And this talk is not about this, but this could be its own 1-hour conversation about how we do this and where. But I'll just say that what's really nice is that over the last 10 years, we've developed a really nice minimally invasive way in some patients, that's appropriate in some patients, to perform this kind of evaluation, and that's with stereotactic EEG electrodes. Again, it's important to kind of go back to the goals of surgery. It's really to reduce or eliminate seizure activity and improve quality of life. So I'll just talk a little bit about this. We're not going to talk about all these things, but I just like to show this slide to really just talk about what kind of surgeries are out there. This is not even an exhaustive list, but I think it's important to have a sense that some of these procedures are what I consider palliative and some of them are what I consider definitive. And the difference here is, what is your goal from this surgery? So the palliative procedures, including things like DBS and RNS, the goal here is to reduce the number and or severity of seizures. The goal is not necessarily to achieve seizure freedom. It's really just to reduce the seizure burden. And still, hopefully improve quality of life. That's when we consider these kinds of procedures. Now, in this category of procedures, our goal is to achieve seizure freedom, right? We're not always successful at doing that, but that is the goal of that kind of the procedure. Again, of course, it's dependent. Every individual is a little bit different. Every case is a little bit different, but typically, if we're performing a resection or we're performing an MR-guided laser ablation, which is really what I'll talk about in a second, the goal there is to try to achieve seizure freedom. And so we would only offer that, in that category of patients. So today we're really talking about minimally invasive procedures. I am going to go over a little bit about one of my favorite advances in epilepsy surgery over the last, really decade or even less, to be quite honest, which is MR-guided laser-induced thermotherapy, or MR-guided LIT, or it's called LIT or laser. There's lots of different names for it. It's all the same thing, and that is. It's a really great procedure that we've been able to do now over the last 10 years, because now we have these really nice advancements in our MRI technology that allow us to visualize relative changes in heat in the brain. So that's been able to give us the precision that we need in order to visualize what will happen when we put in a laser into a specific portion of the brain, and now with very high spatial resolution, we can now know exactly how that heat is transferring around that laser. So we know exactly the type of tissue we're affecting and the type of tissue that we're ablating. And that's really allowed this technology to come about. So, the nice thing is the procedure is performed, patients are asleep. This procedure actually has to be done inside physically an MRI scanner. Different institutions do this differently. At UC San Diego, we're lucky enough that we have an MRI scanner inside of our operating room. So we have a real intraoperative MRI environment. Other centers will either perform the surgery in an outpatient MRI setting, basically turn an outpatient MRI into an operating room, which is what I used to do before we got our intraoperative MRI. Or sometimes surgeons will perform the procedure, start in the operating room, and then transfer the patients down to the MRI to do the procedures. Lots of kind of different ways to do it. All are good ways to do it, but ultimately the ablation has to be done real time with MR-guided imaging. And we talked about MR thermography, which is that ability to visualize heat. So who is a candidate for this type of procedure? Well, basically, after we've undergone that workup that we've just discussed, and we feel that we've localized the region where seizures are coming from, and we ask ourselves a question, which is that region amenable to ablation? Meaning, can we actually ablate this region and not have a consequence, like a negative cognitive consequence? Those are the things that we ask ourselves. And luckily, oftentimes the answer is yes, sometimes the answer is no. If the answer is no, if we think we are going to have a side effect from this ablation, especially one that we think would impact quality of life, then we just don't offer the ablation. Then it's not a viable thing to do, right? Because the last thing we want to do is perform an ablation and actually have a negative side effect on a patient. And so in those cases, then we have to go towards our palliative category of procedures. Then we have to think about RNS, we have to think about DBS, right? Because this is not safe. But in many cases, luckily, we are able to say, yes, we've localized the region, and yes, it's safe to ablate this part of the brain. And so in those cases, we can offer patients this therapy. And so this is just kind of a schematic of how this works. Let's see if I can start this video. In reality, so patients are asleep, they're intubated, it's under general anesthesia. In reality, kind of the patient is draped. But this is kind of a nice just example of the workflow. There's a machine that's localized kind of in the MR area. This is after we've already inserted the laser, which you'll see in a second, into the region that we want to study. And so this is kind of a nice schematic. This really is how minimally invasive it is of an incision. Usually we're making a stab incision. We go straight to the target, and then we put the laser right where we want to ablate, and then we see this real-time image here of what we're targeting, under direct MR visualization. And again, that gives us this kind of extremely accurate spatial precision that we weren't able to get before. Probably my favorite part of this procedure is that, I think I have a slide on it, is this, which is after the procedure, this is kind of the incision for a standard temporal lobectomy, which was previously kind of the workhorse of epilepsy surgery. And now, it's become that. Usually this is actually in the back of the head. But we really can do this procedure, and there's one stitch. This is actually one of my patients immediately after the surgery. And again, one of my favorite things about the procedure is the fact that I'll see patients in their after post-op visit in my clinic, and they just don't have any idea where the incision is. They're like, I'm not really sure. I think it might be around here. I'm not sure. And I'm like, this is great. If you don't actually know where the incision is, I think we've won. So back to some of this data here that I was showing. So, this is the types of outcomes that we get. So it really kind of varies, but what we're seeing is for the appropriately chosen patient, we're getting somewhere between something like 50 to 70% patients who can be seizure-free after this procedure. Now, that's not everyone. It really just depends on the patient, and I, as a surgeon, have a pretty good sense before going into surgery what kind of odds we're facing. You know, sometimes, and it's all based on that pre-surgical workup. If everything just looks so concordant, you know, I sometimes tell my patients, like, I really think you're at the upper end of this curve. I think you're, you know, I think we're really likely to have a really nice outcome from this. Or sometimes I know in advance that there's multifocal epilepsy, and I say to my patients, you know, I think we could try this, and I think it'll really help, but I don't think seizure freedom is likely, you know, after this procedure. So we have a good sense. We have some sense, not a good sense, we have some sense before undergoing something like this, what we might expect. I think this graph is important, which is that it's important to know that our kind of that workhorse procedure I showed with the big incision, the temporal lobectomy, that does still give us slightly better seizure freedom rates, which makes kind of some intuitive sense. We're resecting a lot more tissue, we're perturbing a lot more tissue with that procedure. It does give us better seizure freedom rates, but not by much. It's very similar. You know, you can kind of see these curves. The red is the resection patients, and the blue are the lit patients. And it is not quite as good, but not by much, such that the minimally invasive nature of it is often still quite worth it. We already went through these. Another thing that's really nice about minimally invasive procedures, like almost all my patients go home the next day, usually the following morning. Whereas, of course, with our previous kind of open resective procedures, it was oftentimes like sometimes a 2 to 5 day hospitalization. And then again, probably one of the nicest things about being minimally invasive and more targeted is that we get better neuropsychological outcomes ultimately than we would when we were doing bigger resections. And so, you know, overall, you know, it is really great to now have some more minimally invasive techniques to offer patients. And I think a good take-home point is a lot of this technology has very much just recently been adopted. And so some patients who were evaluated at epilepsy centers even 5-6 years ago might not have been offered this. Whereas now at almost most epilepsy centers, you know, this certainly would be an option. So that's it for me, and then I'll turn it over to my partner here, and then perhaps we can do questions at the end. So actually, while we're setting up here, I'm happy to take any questions.
How long does a robot take?
That's a great question. It's not fast. It's really the truth of the matter. You know, it requires a lot of different studies. Each of them takes time to schedule. Oftentimes, we're also sending referrals for different physicians. Like, I want the patients to see another epileptologist in another location, gather some data. Sometimes we're doing a phase 1 video EEG. Just that takes often months to schedule. And so it's on the average of 6 months, although I'm sure that some epilepsy centers do it more quickly. But most of the patients we're evaluating have had seizures for 10, 20, 70 years, quite literally. So, you know, that blip is not usually too bad just to get really good data. Yes.
So in understand two brain resections, traditional resections, could she still be considered for ablation if that's, or she's already had that, or is that, I mean?
Yeah, no, it doesn't at all preclude you. So that's kind of the nice thing too, is that a laser doesn't preclude a future resection, and a resection doesn't preclude a future laser. You know, both are absolutely possible. And so sometimes when I think my patient might be a good resective candidate, I still might say, let's try laser because it's safe, it's minimally invasive, you know, will save you a big incision, and let's see how it goes. and then we'll follow you at 1 year, see what's going on with your seizures, and then if we're still not happy, then we can consider another phase. And that other phase might be RNS, or it might be resection, or it might be something else.
If a person had a surgical workup within the last 5 years, is that still a good workup for you?
So the results of that workup are still really important, and any epilepsy center doing another workup will want to know what those results were, but almost always we want to repeat definitely elements of that workup, including usually the audiovisual EEG scalp monitoring piece, and certainly the MRI.
Yeah, I think that's a great point. I think one of the reasons that we're able to target things with such precision, as Dr. Ben-Haim mentioned, is that not only are the tools available to us as neurosurgeons better, but the tools available to our radiologists are also better. And often, what may make a difference is that we often talk about epilepsies that are either, quote, lesional or, quote, non-lesional, which just means, do we as doctors see something on the MRI? Do we actually physically see with our eyes a change that might be the reason for the epilepsy? And because the physicists and the radiologists are constantly working to make their interpretation of the scans and even the scans themselves better, a new MRI can actually really help in that kind of workup. So that is definitely something that may be repeated. Really our, not only the workup, but sort of our comfort as physicians and surgeons is as to what we offer patients is constantly changing. Where we might have said, no, you're only eligible for VNS. Now with all the neuromodulation offered, again, we're not talking about that specifically in this talk, but that is something that I think every year, literally, more and more patients are becoming eligible for as we as surgeons and physicians know better who is going to be a good responder to various types of neuromodulation. So just keep up with it, keep on your team, keep being a friendly pest, as they say. So I'm going to go ahead and change the focus a little bit to focus on pediatrics. So a lot of what I do is very similar to a lot of what the epilepsy surgeons do on the adult side, but we tend to have patients with slightly different pathologies. So what we use laser for example, tends to be a little bit different. So I'm going to talk a little bit about why you might want to have your child undergo laser ablation, and talk a little bit about the use of endoscopy, which is a little tiny camera that goes inside of the brain, and how we can sometimes use that for epilepsy surgery as well. Let's see. I do have a couple of disclosures which are not. Hold on. There we go. Sorry. That are not relevant to this talk. So before I talk specifically about peds, I just want to think about the categories of minimally invasive epilepsy surgery. The first is for diagnosis, and Dr. Ben-Haim touched on this a little bit, and the use of stereo EEG. I think this is a critical advance that has come to us as epilepsy neurosurgeons, in that, for us doctors, it's great to use stereo EEG because we can get a ton of information about deep structures that we didn't used to be able to interrogate. And I think it's also great for patients and families. You're still stuck in the EMU for a long time, but just the tolerability of stereo EEG versus grids and strips, it's off the charts. I used to, when I trained in fellowship, we did lots of grids and strips. The way that we did it, we actually did a craniotomy where we left the bone on with the muscle, and it caused all this swelling, and you got this huge black eye. We also put them on mannitol to reduce the swelling, which makes you pee all the time. So the patients had to have a catheter in their bladder for days, and they were just swollen and miserable for days and days. And we would put like the big head wrap, like if you imagine like neurosurgery that happens in the movies with the big head wraps, we put that on. So it was just no fun. Now when we do stereo EEG, I'm done early in the afternoon. I go around on my way out of the hospital at 7 p.m. and they're like sitting there playing on their phones and like having a milkshake, and so it's really, really a much more tolerable thing for patients, and we get better information. So all in all, very good. Ablation is, I think, I would agree that this is one of the most exciting surgical advances that we've had recently in terms of minimal invasiveness, and most of the ablation that we do is laser ablation. Another type of minimal invasive epilepsy surgery is disconnection. So for patients who do not have a focal epilepsy, for patients whose epilepsy may either be multifocal or generalized or based on a very big network, sometimes it's not safe or even really a possibility to get rid of the whole epileptic network. So sometimes we can disconnect the network from the rest of the brain. So that's another type of thing that we can do. And then finally, neuromodulation. Again, we love neuromodulation. They didn't want us to talk about neuromodulation, but make sure you learn about it because it's really cool. So I'm going to mostly focus on laser. So laser ablation, as has already been discussed, tiny little incision, targeting usually something deep. Our workflow, we are not lucky enough to have an intraoperative MRI. If any of you have $30 million would like to fund the intraop MRI at Children's Colorado, please let me know. But what we do is I use the robot, as I'm sure you do, to do the planning. We hook the patient up to the robot, looks something like this. We do use the ROSA robot, but all the other robots are great too. We put in a little bolt through the skull, and I do this in our regular operating room. I then put a little metal stylet, a very tiny little metal stylet, down to the target that I'm going to use, and make sure that we're in the right place. And I check that with a little intra-op CAT scanner. Then we take that stylet out, leave that bolt in place, take the patient downstairs to the MRI. They're still asleep for this whole scenario. And then go to the MRI scanner, and then we hook up the actual little robot and drive the laser fiber into the depths of the target, and then sit at the control desk and watch the MRI heat up the tissue to the appropriate temperature for the appropriate time. So that's how we do it. So the question is, for kids, what type of epilepsy are amenable to treatment with the laser? And essentially what I like to think about for my patient population is patients who have a focus that is deep and is fairly small. So you can't get too much more than about 3 centimeters. If you think of it as, it's really more of a cylinder, but about 3 centimeters in the largest dimension is about what you can get with a laser when you're trying to ablate. I think, gold standard of laser ablation is temporal lobe, and this is great. We tend to do still temporal lobectomies on the pediatric side for a variety of reasons, but lit for temporal lobe does work really well. And I would say probably the number one etiology of epilepsy that is pediatric focused and is really amenable to laser is the hypothalamic hamartoma. So this is something that's very rare, but I feel like here at this conference, this is a conference of 9,000 people who have rare epilepsies. So, I think it's still relevant here. So hypothalamic hamartoma, it sounds like a tumor because it has the oma at the end of it, but it's not a tumor. It's basically a group of cells that formed in the wrong place during development. And gosh, it's really hard for me to stand back here, but I'm going to try. It's way, way deep in the brain and really close to the hypothalamus. The hypothalamus, as you may know, is the center of a lot of endocrine function, specifically growth, urination, and I have 5 minutes left, and also eating. So these tumors used to be taken out surgically, and people would get what's called hypothalamic obesity, which is not just, oh, you weigh a little, like 5 pounds overboard, but this obesity is this just hunger that cannot be sated, and patients, even little kids, would gain 100, 200 pounds in a couple months. Parents would have to like lock the cabinets. It's awful. And lit for HH has all but sort of gotten rid of that. And I can't say how excited I was by this. This is one of the first uses for lit in epilepsy, and Dan Curry at Texas Children's has pioneered that, but it's really fantastic. Another thing that we have had a lot of success with at Children's Colorado is the temporal encephalocele. I would guess you can't even see the temporal encephalocele on this because it's so tiny. Our radiologists have to point it out with magnifying glasses to us. But what we do is the encephalocele is basically a little tiny piece of brain that's falling out of the skull because there's a little tiny hole at the bottom of the skull, and we disconnect that from the rest of the brain, and we've done 5 patients, and 4 of them are seizure free with just this lit, and they've avoided temporal lobectomy or even hippocampal ablation, which is fantastic. Small tumors can cause epilepsy sometimes. Usually these are low-growing tumors. Sometimes they may be called oligodendrogliomas or neuroglional tumors. We can ablate those with laser and have really great success. The insula, which is a deep region of the brain that has often been difficult to surgically access, because often to surgically access that we have to go around some really important blood vessels, and it can be really scary in terms of causing strokes and things like that. Insular epilepsy is fairly common in pediatrics and is really, really amenable to laser therapy. So this was actually a kid in which I was thinking that I was going to do a lit and an RNS. His insurance company said no to the RNS. We did the lit, and he's been seizure free. So he's sort of a annoying story, but also a happy story at the end. And then I will just briefly touch on endoscopy. So endoscopy is the use of a little tiny camera to look inside the brain. It's really great for looking inside the ventricles, which are the fluid-filled spaces in the brain, and we do that a lot. But there are some centers that are doing hemispherotomies, which are big disconnections. Again, we were talking a little bit about disconnections. Big disconnections of one hemisphere from the rest of the brain. There's a couple centers that are doing this with an endoscope. I haven't done it myself, but I think if we as a surgical community figure out really how to do this really well, it could have the benefits of smaller incisions, shorter hospital stays. And then finally, callosotomy. So endoscopic corpus callosotomies have also been done at a couple centers. And again, smaller incisions, probably shorter hospital stay, probably less time in rehab. So those are how I think about, minimally invasive surgery for kids. Again, I think we are all here passionate that everyone who has failed 2 ASMs should be worked up every few years for epilepsy surgery, because it may not be curative, but the palliation is crucial, and it really does make a big difference to patients. 4 categories, just so you can think about it: diagnosis, ablation, disconnection, neuromodulation. We have reduced complications, reduced length of stay, more palatable, not only just in terms of how patients feel after surgery, but about how scared they are before surgery. It's a lot less scary to think, okay, just one little incision and we're just going to burn a little bit of tissue than, oh, big temporal lobectomy or big open surgery. Oops, did I just do this again? I'm so sorry. And I think that is it for me. All right. Thank you so much for your attention. And I think we may have like 30 seconds for some questions.
Much. Yes. Thank you. We have time for just a couple of questions if anyone has some. This is your chance.
You've been questioned out already.
Yeah. Thank you very much for coming to the session. Thanks. I'm so sorry.
Hi.